Hi everyone, I'm Dr. Asghar Misbahi, a medical physicist specializing in radiation oncology. This presentation, I will discuss the daily morning QA of a Linac, which is routinely performed by a radiation therapist before clinical use. Before we look at the specific tests, let's ask a simple question. Why do we actually need to do QA every single morning? After all, it is the exact same machine we used yesterday. Did not move overnight and nobody changed the parts. So, what can really change in just a few hours? The reality is that a Linac is a highly complex machine. It has thousands of electronic, mechanical, and software parts. Honestly, even when the machine looks perfect on the outside, small changes happen. Temperature shifts, electrical shifts, or minor power issues can affect it. Important parts like the MLCs, lasers, and imaging systems can slowly move out of their correct positions. Usually these changes are very small. You cannot see them during normal use, and however, modern radiotherapy requires millimeter accuracy. A mistake of just a few percent in the dose can affect patient safety. Therefore, small changes actually is a big problem. This is why morning QA is just our first line of defense. Now, let's look at this table. This summary comes directly from the AAPM TG198 report, which is our official guide for checking medical Linacs. The entire daily QA can be broadly divided into three key components: dosimetric, mechanical, and safety checks. Together, these tests provide confidence that the Linac is ready for safe clinical use before the first patient is treated. Let's start with dosimetry. The most important parameter we assess each day is beam output constancy. Its tolerance is plus minus 3% for both photon and electron beams. The second component is mechanical and imaging accuracy. The test verified that the machine can deliver radiation precisely to the intended location. We checked the alignment of the room lasers, ODI or optical distance indicator, and collimation size. For conventional treatment, laser accuracy is typically required within 2 millimeter, while for high precision techniques such as SRS and SPRT, the tolerance is often reduced to 1 millimeter. And the last part is the radiation safety. These tests are difficult because they don't use millimeter measurement. Instead, they are strict pass or fail tests. First, we check the door interlock. Then we check audiovisual monitors. And then we make sure that beam on indicator lights are working. And if we have radiation area monitor, we will check that if it is working or not. The other parameters here and our items should be checked is one of them is wedge. We should make sure that the dynamic wedge or physical wedge are working. And when we make exposure using the wedges, they are functional and their activity is normal. Another important component of daily QA is imaging part and MLC. Let's talk about the MLC. For multi-leaf collimator, TG198 requires a daily check to confirm that the leaves are moving correctly and that leaf position constancy is maintained. We are verifying the MLC system for all treatments because MLC are responsible for dynamic IMRT and VMAT and sometimes for very complex treatments like SPRT and SRS. And the other part is imaging system. Imaging system is the eye of the linear accelerators. Daily QA includes checks of both KV and MV imaging to ensure they maintain accurate scaling and geometric constancy. The most critical assessment here is the imaging to treatment coordinate coincidence. In simple terms, we need to confirm that the center of the image used to localize the target correspond exactly to the center of the treatment beam. Now we will try to look at these tests with details, and I will try to review in detail. When we talk about daily QA, our ultimate goal is simple: total confidence. We need to know what with absolute certainty that we are delivering the correct dose to every patient during every single fraction. To achieve this, our primary check is the constancy and accuracy of our photon and electron beams. But there is an important distinction to remember here. This is a confirmation, not a calibration. We are not here to fine-tune the machine output. We are here to verify that the machine is still performing exactly as it was calibrated by the physics team. The bottom line is patient safety. We are ensuring that the beam output remains within a tight tolerance, typically plus minus 3%. Beyond just the dose output, modern daily check devices allows us to verify several other critical parameters simultaneously. Beam symmetry and flatness is one of them. We ensure the radiation beam is uniform across the entire field, so the dose is distributed evenly. Energy constancy, we verify that the beam penetrating power has not shifted, ensuring the dose reaches the intended depth. And we check the field size. We confirm that the light field and the radiation field are perfectly aligned. Our next test is related to our visual guide of the patient positioning, the laser system. At the time of installation, these lasers are perfectly aligned to either the radiation or mechanical isocenter. In a standard setup, we rely on 4 units. I mean the laser units. 2 lateral, 1 on the ceiling, and a sagittal laser at the foot of the couch. Together, these create the coordinate system we use to align our patient in 3D space. It is important to remember that these aren't just light bulbs. They are sophisticated electronic systems. And like any electronic system, they are subject to drift over time. This is why we have strict daily tolerances to maintain. For non-IMRT machines, the daily tolerance is typically 2 millimeter. For SRS and SPRT machines, the margins are so tight, so tolerance drops to 1 millimeter. If lasers are your primary setup tool in patient setup, any drift directly translates into positioning error. To hit the target and spare critical structures, we must keep these errors within 1 to 2 millimeter window. If we are using IGRT for patient setup, and we know that IGRT system provides the final corrections, we still need the lasers to be accurate. A stable laser baseline ensures that the shifts we see on our screens are meaningful and, and the patient is starting in a consistent position every day. Now let's review the daily QA protocol for optical distance indicator or ODI. As you can see in the figure, we have a ruler type scale and it can be seen on the patient skin when we are doing setup. The primary objective here is to confirm that our optical distance tracking remains accurate over the time. This is a traditional but vital mechanism used daily for setting up the source to surface distance during patient treatments, especially in electron treatments. And for phantom dosimetry, for physics, we are using this optical distance indicators as a setup component. Clinically, the ODI serves as an essential safety redundancy to our coronal wall lasers. It becomes our only reliable setup reference if the patient surface happens to be positioned completely away from the machine isocenter. For example, if you are treating a patient with electron beam at a distance of 110 centimeter, our setup reference will be ODI. So we should make sure that the distance provided by the ODR is correct. Maintaining strict accuracy here is critical, as any physical distance error in a SST setup technique are heavily magnified by the inverse square law. It means that if we increase the distance from the applicator, our electron output changes significantly and we can underdose the tumor. Because of this clinical impact, our daily tolerance limit is strictly set at a plus minus 2 millimeter. Let's review daily QA protocol for optical distance indicator or ODI. The primary objective here is to confirm that our optical distance tracking remains accurate over time. This is a traditional but vital mechanism used for setting up the surface to source distance during patient treatment and regular phantom dosimetry for physics work. Clinically, the ODI serves as an essential safety redundancy to our coronal lasers. It becomes our only reliable setup reference if a patient surface happens to be positioned completely away from the machine isocenter. Maintaining strict accuracy here is critical as any physical distance error in the SSD setup are heavily magnified by inverse square factor. Because of this clinical impact, our daily tolerance limit is strictly set at plus minus 2 millimeter for ODI. To keep our morning workflow efficient, we should use a easy verification method. This procedure assumes that our room lasers have already been checked and correctly coincide with the machine's radiation isocenter. So we place a flat surface on the couch at the exact machine isocenter, which is normally 100 centimeter on the modern Linux. We project the ODI onto the surface and verify that our crosshairs match up. The test successfully passes when we visually confirm that the room's coronal lasers precisely graze the exact surface illuminated by ODI field light. On this slide, we focus on the verification of the machine collimator Joe indicator. The core purpose here is to confirm that the These physical indicators, the field size indicators, which shows the jaws positions, accurately match our programmed beam field edges. Maintaining this accuracy is vital for clinical integrity because jaws work the jaws work with MLCs or blocks to strictly define our treatment boundaries, cover target volumes, and shield nearby critical structures. Looking at our tolerance limits, non-IMRT and standard IMRT machines allow a variance within plus minus 2 millimeter per jaw. However, for high precision SRS and SPRT machines, that tolerance tightens significantly to within plus minus 1 millimeter per jaw. To perform these checks, we position our testing surface directly at the machine isocenter. We can use a visual method projecting the field light onto graph paper and see the deviation between our graph paper borders and field light, or a predefined template. As you can see here, we have a template showing different field sizes. And we can use this template as a surrogate for the beam. Or sometimes on the Daily QA hardwares, Daily QA detectors. Alternatively, we can use the surface of that device as a field size checking uh, protocol for us. Now we are talking about safety checks. Safety checks are strictly pass or fail. If a safety system isn't working perfectly, the machine cannot be used to treat patient that day, and physics must be notified immediately by RTs. To test the interlock system, you will perform two quick steps. First, during your morning beam warm-up, simply crack open the treatment door. The beam must cut off instantly. Second, leave the door wide open and try to hit beam on from the console. The system must completely block the beam from turning on, and a clear door interlock fault should pop up on your screen. Finally, let's talk about physical safety. These massive vault doors can weigh up to 15 tons to block the radiation, and the motors close them with incredible force. To make sure that the built-in safety features are working, activate the emergency push bar or proximity sensor while the door is halfway through its closing cycle. The door must stop moving instantly. Make sure these safety loops function perfectly every morning is your first and most important task before any patient steps into the room. Another safety checks and safety QA is related to audiovisual monitor. The audiovisual monitors and console intercom system is very important as a safety devices. As therapists, once you step out of that vault and close the heavy door, these monitors become your eyes and ears. Continuous visual and audio contact with your patient is not just good practice, it is a strict legal and clinical requirement during every single fraction. Like our door interlocks, this is a strict pass or fail check. During your morning QA, turn on the console screen and check every camera angle. You need to make sure that the picture is crystal clear. color accurate, and gives you a complete unobstructed view of the patient and the treatment couch. Next, test two-way intercom. You need to be 100% sure you can hear everything inside the room clearly, whether it is a patient's breathing pattern or verbal question or sudden call for help. Here is a critical clinical rule you must always remember. If your audiovisual monitors or intercom fail at any point during a busy treatment day, you must immediately stop treating patient. Even if the Linac itself is working perfectly, the dark screen or broken microphone means the machine is down until engineering fixes the issue. Beam on indicators. As you can see on the picture here, just above the maze entrance door, we have beam on indicators. The beam on indicator light located outside the treatment vault, as you can see here. The lights are designed to give anyone in the vicinity an immediate, unmistakable warning that the Linac is actively producing radiation, preventing accidental entry into the room. Just like our other safety features, this check operates strictly on a pass or fail basis. To test these indicators during your morning QA, you will look for specific things while the beam is firing. First, look at the external light mounted right above or next to the vault door, bunker door. That means it must light up brightly. Then check your control console to ensure its built-in status indicator matches the room lights perfectly. Always keep in mind that if any of these bulb filaments burn out or warning circuit fail, the machine is legally down. You cannot treat patients until engineering replaces the indicator because an invisible hazard must always have a functional visual warning. As we wrap up today, let's remember that daily QA is an essential part of the safe and effective radiation therapy. By performing these checks consistently, radiation therapy technologists help ensure accurate dose delivery, maintain equipment performance, and protect patient safety. I should mention here that always follow your department's QA procedures and manufacturer recommendation in accordance with national and international guidelines. Thank you for watching. If you found this video helpful, please like, share, and subscribe for more educational content on radiotherapy. Together we can deliver safer, high quality radiation therapy for every patient.